So, hello everyone. It's Dr. Vikas Jain. I'm a TUGSS India, TUGSS Asia Chief Coordinator. And from last 2.5 years, I think we are coordinating these programs for every month on every Friday, every second Friday. So this time today, we are going to present some extensive lectures on the complications related to the bariatric surgery. Though I am myself is not a bariatric person, so rest of the program, Dr. Christopher from the TUGSS Bariatric Coordinator, he will carry on for the programs. He will introduce the sequence and all the faculties for today. So it is over to Christopher to run over the show for today.
So thank you, Dr. Vikas, for the introduction, and I welcome everybody for the bariatric webinar today. So today we have three speakers, all eminent speakers, Dr. Sarfaraz, Dr. Arpana, Dr. Nandakishore Dukkapati, and also we have panelists and moderators like Anirudh Rajkumar and Chirag Parikh, Nidhi Kandelwal, and myself. So we are starting the show. So we have the first speaker, Dr. Sarfaraz, who needs no introduction. He's a director of a digestive surgery clinic, Bellevue Hospital, and a consultant in the city of Kolkata. He's been practicing for more than 20 years now, and he's expert in all laparoscopic, bariatric, hernia, and AWR surgeries, as well as colorectal surgery. And he's actually a good orator, good author, and also he is a good writer. And he writes a good poem. He has even told a poem right now. So I'm happy to introduce Dr. Sarfraz sir, and he always motivates the young surgeons like us, and he's always a good teacher. So his talk is on sleeve leak, and I welcome you to present your talk, sir.
Thank you very much, Christopher, for that introduction. I'll not waste any time. I understand that. Yeah, I'm just going to drag this down a little bit. Yes. Yeah. All right. So hopefully you can all see my slides.
Yes, sir.
Already been introduced, so I will not go into this any further. Yeah, that's the beautiful hospital that I work in. And I will be presenting a concise synopsis of leaks after sleeve gastrectomy. You can imagine that this is a huge topic. And before I came here, I was thinking in the last 2 hours how to present this in a manner that it can be beneficial to everyone, especially somebody who is wanting to know about this subject for the first time. So I wanted to put in things which are basics and also things which are in the form of an algorithm. So first of all, sleeve gastrectomy, as you know, is the commonest bariatric procedure done worldwide. And back in 2011, the incidence reported 0.7%. Then there were many literature which varied from 0.2 to 7%. But at least in my practice, I can say that this is exactly where it stands. So it is not a very common thing to happen. However, when it happens, it is the mother of all leaks. In fact, you can call it the mother-in-law of all leaks. Now, a good thing to understand is that unlike other leaks, the sleeve gastrectomy leak or a gastric sleeve leak is the staple line leak. The commonest thing that happens here, etiopathogenetically, is that the most proximal staple line blows out. So there's something happening at the proximal staple line and it blows out. And therefore, a gastric sleeve leak is actually a proximal staple line leak almost invariably. Now, I will not go into how to prevent it, rather to make sure that I utilize these 10, 12 minutes very well. I'm going to confine myself into its treatment because that's where the major important issues lie. So first of all, as I mentioned, the location is usually the proximal staple line, which is like about, surgeons would fire 5 millimeter to 10 millimeters away from the G junction. And typically in that area, you would see a leak. So if one has not burned the esophagus, which would then be the reason behind that leak, usually it is just the proximal staple line which is blown out. And the reasons forwarded for this is that there is thin gastric wall at that area. And there is increased intragastric pressure, which has been documented in various experimental studies. So when you convert a hollow hemisphere balloon into a banana, then the gastric pressure is rising. And many times, functionally and anatomically, we are creating an incisal stenosis. So all of this leads to higher pressure at the proximal staple line, which blows out. And the other mechanism, which is probably more important, is there is tissue ischemia. Typically, many of these leaks happen after about 4 to 5 days, which suggests that these are not technical leaks. These are leaks because of ischemia. And that is usually attributed to the loss of vascularity. So while we are doing sleeve, as we know, we are cutting off the vessels from the greater curve and also some of these retrogastric vessels. So some of these vessels are probably, which are getting divided if as a part of the surgery. And if you have one surgeon is aggressive, might divide more, there's tissue ischemia, and that may lead to leak. Now, before I go into the management of the leak proper, we need to classify these leaks because they tell us about something about how to manage them. So that is the importance of knowing this classification of leaks. So there are many classifications. I've tried to put in those which are important clinically. So this is Rosenthal's classification. Early leak, that's 1 to 3 days, and this is usually a technical factor. Maybe the two staple line intersection didn't form perfectly well, or there was a hematoma which led to blow out of the staple, or the staple line thickness and the tissue thickness was disparate. So these are the reasons why we may have an early leak. Anything that happens after 4 days is called, till about 7 is called intermediate leak, and more than 8 is late leak. But again, anything after 4 or 5 days is important to understand that these are all ischemic leaks. So the management is going to be different. The first early leak may still be amenable to suturing or an omentopexy, but that's again pretty uncommon in our practice. But these tissue ischemia leaks, which are intermediate and late leaks, there is no point in trying to suture them or doing anything except for doing some sort of an endoscopic therapy. The other classification is type 1 and type 2, and it is important because it tells us there are some leaks which are subclinical. There's no sepsis, there's no dissemination of the contents, whereas the other one is type 2, which is clinically the patient presents with features of sepsis, tachycardia, tachypnea, fever, pain. So in this, you may document in radiology and contrast studies, abscesses and contrast leaks. So type 1 and type 2. And this is the most recent classification, and I find this pretty useful. It's Johari's classification published in 2022. And this captures about everything that we see in our clinical practice. So bear with me. Class 1 is the phlegmon associated with the staple line. Whereas in 1B, the phlegmon also has got some extra luminal gas, which means there is extravasation of gas, air. In 2, there is liquid component. So there's just a solid and gas component in 1. And in 2, we have a liquid component. So there's a fluid collection with some gas. And when that is extensive, it's called 2B. So remember, in 2, there is an abscess. In 3, you can document a contrast coming out of the stomach into this cavity, which is 3A. But if it is going in freely into the intraperitoneal cavity, it's 3B. And if the fistula is communicating with the pericardium, pleura, colon, then these are fistulas, chronic fistulas, or it could be gastrocutaneous. So all these are chronic fistulas, they are class 4. So this actually captures everything. We can understand that class 4 is got to be a chronic fistula, and the others can be in acute setting. So it's important to see this and understand this recent classification. I find it really helpful. Now, how do these patients with sleeve leak present? Well, from bottom to up, the most subtle thing is that there is no symptom and there's just a radiologic leak, is a contrast extravasation. It's pretty controversial how to treat them, but many times you wouldn't do much about these patients. Although some surgeons may be very aggressive, some may be very conservative with this. But then some patients will present with dizziness, just dizziness. And that's a subtle sign, a subtle symptom that one needs to pay attention to. And some people will be very obviously complaining of a chest pain, a shoulder pain, abdominal pain. Some will be screaming out with their features of sepsis like tachycardia, tachypnea, fever, and blood pressure is going down, and they can come into shock also. Now, the important thing to understand here is one must have a very low threshold to document these leaks, because an untreated, undetected leaks can present later with either a chronic fistula or a chronic abscess and poor, chronic abscesses. So knowing them early is important. Whether we'll do anything about them is a different story, but knowing them early. So knowing these things and putting in the investigations to detect it is important. Now, the most important investigation is a CT scan, obviously. And a CT scan can be given with a gastrograph in contrast to just see if there's an extravasation or any other contrast which may help. You could also use an upper GI series like a gastrograph in meal to document, but the gastrograph in meal will not pick up any event in the peritoneal cavity. And you will see in the subsequent slide why it is important. So the CT scan will pick up the leak. It will also pick up the events in the peritoneal cavity, whereas the upper GI series cannot pick up that. Endoscopy usually is avoided in the first week, but once you get patients who are coming late to you, endoscopy will be important to localize and then also for therapeutic endoscopic purposes. I like to imagine that when we manage sleeve leak, we are looking at two things. One, how do you manage the peritoneal collection, and how do you manage the leak per se? And the leak may not be a leak alone. It may be associated pretty frequently with anatomical or a functional incisal stenosis. So these two things are there in the mind. The first one can be tackled laparoscopically, radiologically, that is a peritoneal collection. And the second one, obviously, will require some sort of an endoscopic therapy, and if it's chronic, some sort of a surgery. So the management actually depends on the clinical condition, the timing of diagnosis, whether you're getting these patients early or late, clinical condition like stability of the patient and the sepsis of the patient. More sepsis, more instability, more in favor of doing a surgery. If you're getting them early, then of course stent is what you're looking at generally. But we will see how things are changing rapidly in that area. Location of leak, usually it's a proximal leak, so that's a thing. The size of the leak is important because some endoscopic therapy are not possible unless the leak size is big. As soon as we diagnose these patients, let's say whichever day we are diagnosing, on the second day, third day, 7th day, 10th day, you have to admit the patient, put them nil per mouth, start intravenous fluids, start giving them some parenteral nutrition, try and see if you can get an distal enteral feeding in the form of nasojejunal. PPI is given to suppress all the acids so that the output from that gastric tube is less, and of course, systemic antibiotics. And very importantly, as soon as we get a sleeve leak, now we have come of age where we have understood in the last 15, 20 years that we have to have a gastroenterologist, a radiologist, and a bariatric surgeon on board. Sometimes a gastrosurgeon also on board. So all these people will have to be on board for the most effective therapy depending on the situation. Now, this is a patient which the very next day, this patient complained of pain. There was tachycardia, tachypnea, and we had to go in, and you can see the very, very old video, but I could hunt it out, and you can see that there is a leak at the top. Now, this is 24 hours or 48 hours later, and therefore, this could still be a technical factor. So arguably, we can put in a stitch at the most proximal part and hope that that is going to work. In this patient, it didn't, but it's something that you can do. However, if these patients present, let's say, 5th or 6th or 7th day, there's no point in trying to even give a suture. Just let the momentum be there, and you have to start thinking of some endoscopic method or strategy to deal with them. Now, if you have to read one article for this entire subject of endoscopic management of sleeve leaks, I would suggest you read this, which is published recently by Muaz Masood, a good review, which has everything. So what are the options endoscopically when we see these leaks in an acute setting? So there's a stent, which is the covered self-expanding metal stents, CSEMS. Internal drainage with pigtail stents, we'll come to that soon. Endoluminal endoscopic vacuum therapy, septotomy. And then the next three are unimportant. They are usually as adjuncts, that's the over-the-scope clips, suturing with an Apollo over stitch, tissue sealant. So these three are less important. But let's look at these four. So the stent is the most common approach used worldwide for acute sleeve leaks. As soon as you have a leak, well, you could think of just doing a lavage, putting in a drain, and hoping that this fistula is going to work. This control fistula is going to go down with time. However, more often than not, if there's a stenosis or if there's a high output fistula, you would want to do something actively, and the stent is the right thing to do. It comes with its own problems, and you will see this a necessary devil, as we say. So it's the commonest approach. It's a treatment of choice if you've got a leak with an associated incisal stenosis. Then there is no other option. The leak size should be a little low, less than 2 centimeters, but then there's again arguable. The leak has to be proximal. And the stent is not the same as the stent used in, if you're a gastrosurgeon, you would know that after a total gastrectomy and esophageal jejunostomy, if there's a leak, the stent that we use there is a shorter stent, right? But this is a long stent. So this TUGSS mega stent made in Korea is a bariatric specific stent. There are some more now, but this was the one which came in very early. And the important thing is that you have to put it in the distal esophagus, and the distal part has to go at least up to the pylorus. So the reason why this is so long is to make sure that the sleeve is straight, you overcome the stenosis, you have taken care of the side leak on the proximal G junction, and then we can expect that if it's left for 6 to 8 weeks, this will work. So very important. But you can imagine if you do this, you will also have a lot of duodenogastric reflux. So a downside of this stent, mega stent, is the reflux. Sometimes you may have to add pigtails before you put in a stent, but it's important to understand the stent is not the same as the other stents that we know. The most important criteria that one must satisfy before putting in a stent that the patient should be non-septic. You must have done radiologic or laparoscopic drainage of all the abscesses that are there. So there should not be any peritoneal collection. Leave it for 6 to 8 weeks. Initially, you can't feed them. You have to have a nasojejunal tube to feed them. And PPI has to be given to suppress all the acid from there, as I mentioned earlier. But the real downside is the reflux, the chest pain. Sometimes the stent can migrate. Remember, it's a covered stent, so it's slippery on the outer side, precisely because you want to remove it. It's a temporary stent, so you have to remove it. That's why it's coated. But the same reason also makes it migrate distally, and there are reports of the stent migration distally into the small bowel. And finally, you have to remove sometimes because the patient can't tolerate. The success, however, is very high. Now, the other one is the internal drainage with the pigtail catheter. And you can see in this diagram that if you have a contained abscess cavity, then you can put in the pigtail endoscopically, dilate the incisural level with the balloon. And if that can be done, this technique of endoscopic internal drainage has been shown to be superior to the stent in some regard, and I'll come to that immediately. But remember, there's a prerequisite. The leak size should be such that the endoscope can go through it, and we can debride it, and then we can put in the pigtail. Sometimes we have to do a septotomy to achieve this. So the success rate is pretty high, but look at the mean treatment duration is pretty long. It's almost 3 months. But the advantages over stent is that it's better tolerated. They have no stent, no reflux, so no chest pain, is better tolerated. It allows for early feeding, which I think is a great advantage. And there is the major advantage that with the stent, still it is reported out, despite the stent being placed, these leaks have been converted into a fistula going into the pericardium, pleural cavity, colon, and gastrocutaneous fistulas. However, when you do pigtail method, then the chances of having any of these fistulas are very low because you're internally draining these abscess cavities. The same principle is applied when you have a vacuum over a sponge. And this is similar to the negative pressure wound therapy one uses for sepsis after a laparotomy. You can put in the sponge onto the leak site and apply a negative pressure wound therapy. And by doing multiple sessions, one can, one can treat the leaks. And this has become a front runner strategy in many centers in the world. I'll show you 2 algorithms, and you will see how there are 2 kinds of world as far as sleeve leak is concerned, and this particular technique is very promising. This is the endoscopic septotomy. I got this patient referred from another center, and when we did this, this was about 2 to 3 weeks later, we found there's a large abscess cavity. The contrast is going into the abscess cavity. So that is the contrast going into the abscess cavity, and the sleeve actually was compressed. So what we did, we could see on endoscopy 2 openings. We cut the septum in between. Now this was 2 to 3 weeks later, so the septum was good enough to be cut with the diathermy scissors, and that led to decompression of the cavity into the stomach. So that is endoscopic septotomy, and it is pretty good. Now, just a few words about the over the scope clip. Well, it has been used for very small, tiny holes, but more often than not, these are used as adjuncts to fix the stents from preventing them from migration. Standalone OTSC is rest done because of poor efficacy. Even suturing has been tried, but good tissues are not there on the sleeve leak margins, and therefore, again, these have not worked. Usually used as adjuncts again to prevent stent migration. Sealants have come in, the fibrin glue and cyanoacrylate, some promises, some good literature, but really not too big a case series to promote it. But well, worth a try, because these are situations which are dramatic, and whatever helps is most welcome. I'm going to look at 2 algorithms now based on what I've told you so far. The first one is the SAGES algorithm, which is rather simple, written by the primary author was Dr. Nimri, my good friend. And this appeals to me, and I think this is what we follow here. There are 2 leaks, the early leak and the chronic leak, which means more than 90 days. The early leak, if you see a patient is septic and unstable, obviously go for laparoscopy, drain, and put in a lavage and the drain, and let the drain manage it. If that fails, then you think about some more surgeries, more difficult surgeries. However, if there is early leak and the patient is not septic, not unstable, then one can manage the sepsis with radiologic drainage and the leak per se with a stent. If there's no stenosis, you may use theoretically a short stent, but I think most bariatric surgeons do not want to go in there. They want to use a mega stent. So they use a long stent, assuming that there is some stenosis, and that is what is used in early leaks. Now, if you look at these strategies, when they fail, you simply go to what we do for chronic leak, which is basically resuscitate these patients, give them good nutrition, build up their albumin and hemoglobin, and do either a total gastrectomy and a esophagojejunostomy, or you can do a fistulojejunostomy, or some authors have also said just do a Roux-en-Y gastric bypass, and that will bring the pressure from a high pressure system into a low pressure system. It will work. Now, between these 3 strategies, I must say that all have been reported, but the commonest one, which is practiced, is the total gastrectomy with the esophagojejunostomy. And then this is another which I have picked up from the review that I was talking about. And here you would see that everything is the same, except then when you look at the unstable patient, well, you want to do a washout and drain, yes, but instead of doing a stent, they are using endoscopic whack therapy right from the beginning. Again, in the stable patients less than 90 days, the evac comes before the stent or any other technique. So there are centers which are moving into the endoscopic vacuum therapy. The reason is that the endoscopic vacuum therapy, just like the pigtail, does not lead to gastrocutaneous fistulas with the pericardium, pleura, and things, the horrible things that we have read in the case reports published in literature. So I think this is an interesting age and phase of sleep leak career. We will have to see where it is going. We'll have to watch this space carefully, but I just wanted to share these 2 algorithms with you guys. So the take-home message from my talk is the incidence of sleep leak is low, but the outcome is delayed, that the repair takes a lot of time. Your patients are hanging around with you for a few months. It's unpredictable. Sometimes it leads to fistulas, and that's a very bad thing to happen. Always have your surgeons, your radiologists, and your gastroenterologist along with yourself. And make sure in the unstable patients, we go in early with a low threshold of suspicion, and use stents in early leaks. But nowadays, some people will use endoscopic vacuum therapy if expertise is available. It's simple, actually, not too difficult to use. And finally, if you get the patients later on, after 90 days, they're chronic leaks, then you will have to do some sort of a surgery, revision surgery, in the form of total gastrectomy, esophagojejunostomy, or a fistulojejunostomy, or a Roux-en-Y gastric bypass. So that's about it from my side. I have tried to pack in things which are basic as well as something which is coming up in the horizon. I hope this was useful to you. Thank you very much, Tugs, for giving me this opportunity. And I'm open to questions from your side.
Sir, it was an excellent presentation. So, as a moderator, I just have two questions. One is, what is your take-home message for the youngsters like us to prevent sleeve leaks, and how to predict or manage later? So, just a few points on that.
Yeah. So prevention of sleeve leaks, I purposely omitted from this talk because I wanted to, keep it smaller and not too detailed. But the foremost thing that I have seen that happened in my practice is that I've started making sleeves straighter, a wider incisura, and staying away from the G junction after having mobilized the fundus pretty well. So again, I will say this again because it is so important. So how do I think about it? I do a good amount of adhesive on the sleeve now, even at the body level from the pancreas, even at the fundus level from the left cruise completely, so that entire stomach comes out laterally towards the left, and I can see it from below upwards as something that I'm going to fire a straight line on it with a wide incisura. I always use a reticulating stapler, which helps me in keeping the incisura wide, but I think that can be managed with having two 12 ports on two sides. And after the wide incisura going straight, not having too much of assistant giving traction to you, just leaving it alone, leave the sleeve hanging on with the gravity and firing your staplers, keeping your tips at the tips of the staplers at the tips of the veins and going straight up. And when you reach up, stay about a centimeter away from the G junction. That's about it. I think keeping it straight is pretty good. And nowadays we have got excellent staplers. And I always use only purple from top to bottom. I don't make it smaller at the fundus. So the staple line, I don't want to crush the fundus, so I use only a purple stapler. But that's me, and I'm sure everybody who is doing their own bit is learning from their own experience, and we are pretty superstitious the way we do sleeve. If something is working for you, just stick to it.
Okay, sir. And about the intraoperative leak test, will that prevent the diagnosis of leak? What is
So
your
I think again a great question, Christopher. So if there's a technical factor, yes, you would pick up something. If it's an ischemic leak, you pick up nothing on the table. However, there's no harm in spending those couple of minutes doing the methylene blue test or the air test, whatever you do. There's no harm. I have at least seen twice in not in my practice, but I've seen it when I was there in the OR, that there was a hole in the esophagus, and that was picked up by the methylene blue. And that was not because of the staple line, it was because of the harmonic scalpel damage. So I would say that it is a good practice to do a methylene blue test, and those couple of minutes are definitely worth it. But
Thank
you
you,
won't
sir.
pick up all.
Thank you, sir. Nidhi, over to you.
Thanks, Christopher. Thank you, Sarfaraz sir. That was you actually really did summarize it extremely well. We'll move on to the next part of this session. So the next talk is going to be by Dr. Aparna Govil Bhaskar. Just to introduce Madam, she is a bariatric and laparoscopic surgeon associated with Cefi, Apollo Spectra, Curie and Namaha hospitals in Mumbai. She is an EC member of OSCE at present. She is amongst the first Indian bariatric surgeons to be accredited by SRC for excellence in bariatric surgery, and truly that honor is very well deserved. She has a very keen interest in research and has multiple clinical publications to her name. She has also authored 4 books and multiple chapters in various textbooks. And one of her books, which is on doctor-patient relationships, which is Dear People with Love and Care, Your Doctors. It's been on the bestseller charts for almost 5 years now. And Madam is going to address a very sensitive subject for all bariatric surgeons, that is weight regain. So over to you, ma'am.
Thank you so much, Nidhi, for the kind introduction. I'll just share my screen. Um, I think this isn't really a complication, but very important nevertheless. Um, is it full screen?
No,
Not yet, ma'am.
Switch on slideshow, please.
All right. Is that better?
Yes.
Yeah, it's perfect.
All right. So, good evening, everybody. I think it must be good afternoon and good morning for some of you. Thank you very much to TUGSS and Dr. Vikas and everybody who's helped to organize this webinar and having me here. I am going to be talking about recurrent weight gain and management. Recurrent weight gain is something which I think not only manages to press the panic button for the patient, but it also gives a lot of stress to a bariatric surgeon as well. I have no disclosures pertaining to this talk. These are some of the few books that we've done, which Nidhi spoke about. And I've had the great honor to have done one of these books with Dr. Beg, who was the previous speaker. So coming to the topic, we know that metabolic and bariatric surgery leads to significant weight loss, along with all the other positive outcomes in terms of improvement in comorbidities and improvement in quality of life. And it is currently the gold standard treatment for clinically severe obesity. So out of all the therapies that are available for weight loss, be it diet or lifestyle modification, pharmacotherapy, or any other therapy, endoscopic therapies, today surgery is definitely the best option for clinically severe obesity. However, what we also have realized over a period of years that there is no consistent degree of weight loss that our patients experience, and there is a huge amount of inter-individual variability in response to treatment, which could be diet, which could be pharmacotherapy, it could even be surgery. And it is also now known, and we also see it through our experience, that some of the beneficial effects of bariatric and metabolic surgery, including weight loss, including improvement in comorbidities and quality of life, may actually diminish over a period of time. And there could be some degree of recurrence or weight gain in the long term. Now, this is a graph which shows that weight regain is actually a reality after any kind of bariatric operation, be it gastric bypass or banding or sleeve gastrectomy or any other. In fact, I've seen weight regain even after very maladaptive procedures like SADI as well. Now, we need to destigmatize weight recurrence to some extent. Like I said in the beginning, this really pushes the panic button for our patients. They do come out from a very insecure place when it comes to weight. And weight loss post bariatric surgery leads to a lot of euphoria in our patients. And the moment they start gaining weight, I think they start panicking and they get really, really stressed. So what we need to do is that we need to accept that some degree of weight regain after surgery is normal between 2 to 10 years. First 2 years is known as the honeymoon period, where usually we don't see any kind of weight recurrence. But after that, we see that depending on many factors, there is variable degree of weight recurrence that can happen. Now, what we also need to understand is that weight regain is neither a patient nor a surgical failure. Failure is a word, I think, which we should remove from our vocabulary when we are treating obesity. Just comparing it with oncology, I think Dr. Vikas is an oncosurgeon, and when cancer recurs, we never say that the surgery failed. It is usually the disease that has progressed further. So same is the case for obesity. I think we need to kind of change the vocabulary that we use. So the other thing about using words like success and failure are that they put the onus either on the patient or on the doctor, and also add to the stigma which is already there around obesity. And we need to probably start using words like response, non-response, recurrence, and shift the burden from patient to disease and its treatment, just like we do in any other disease. Now, some points of reflection. We need to understand that bariatric and metabolic surgery is not a magical cure for obesity. What it does is it controls the progression of obesity for months or even years, and it controls it really, really well. At times, patients may experience prolonged remission after surgery, and eventually, in some cases, obesity may come out of remission and it may then be called disease progression, or disease recurrence, it is definitely not failure of surgery. And progression is a sign the treatment may need to be escalated at that time or may need to be restarted. And we need to get obesity back into remission, just like we do in oncology. Now, we need to define weight regain. And before we do that, we need to understand what is successful metabolic and bariatric surgery. Now, as in cancer, we have 5-year outcomes. We yet do not have something like that in metabolic and bariatric surgery because this is an evolving field, it's a newer field, and we are yet to mature to that state where we are actually able to define that. Now, we also need to understand whether weight regain is really enough to justify further treatment, or do we also need any kind of deterioration in the comorbidities, or do we need to figure the quality of life parameters before we actually think about further treatment for this. So which metric should be used to measure it, whether we should be using the excess weight loss or we should be using the total body weight loss? I think the world has moved towards using total body weight loss now. And whether further therapy is necessary, if yes, then which kind of therapy? Are we talking about increasing the diet effort of the patient? Are we talking about exercise effort? Are we talking about adding medications? Or are we talking about revision surgeries? Or maybe a combination of all of these. So what about definitions for weight recurrence? Unfortunately, in the bariatric literature, we do not have any one definition for weight recurrence. We are yet to reach to that level where we have uniform terminologies for this. I think our terminologies have changed a lot over the last few years. Till very recently, we used to use excess body weight as the standard metric, and some of these definitions were based around that. So there are various definitions. One of the definitions said that if the initial loss is more than 50% of the excess body weight, then it is considered a successful surgery. According to Reinhold, which is a very, very old definition, excellent outcome was if the BMI drops to less than 30. It was good if the BMI was between 30 and 35, and it was considered poor if the BMI remained above 35. Now, here there is a lot of criticism to this because patients with very high BMI, patients who have BMI more than 60 or 70 may actually not touch these kind of lower BMIs in their lifetime. So that would not mean that they haven't achieved a good result. Now, another definition, which actually is probably the most correct one, is the one which says that weight loss which induces remission of obesity-related comorbidities and actually improves the patient's quality of life is probably the most successful outcome. However, there is a lot of ambiguity in this. We don't have anything objective to measure, and hence it becomes very difficult to replicate and to reproduce in practice. Now, in a recent review in 2020 by El Ansari, there were a lot of these weight loss definitions, which were definitions of weight regain and inadequate weight loss, which were taken from the literature, everything that has been used. And weight regain was defined in many ways, and one of them being by using excess weight loss percent. And they said that if the patient regained about 25% of their excess weight from the lowest weight achieved, then it could be considered as weight regain. Some of these definitions said that if the patient actually gained more than 10% or more than 10 kg from the nadir weight, then it could be considered as weight regain, and so on. And inadequate weight loss was actually defined as excess weight loss percent less than 50% at 18 months. Now, definitions of inadequate, just give me a second, please. So definitions of inadequate weight loss and weight recurrence. Now, total body weight loss is generally the standard metric that is being used in obesity and to define weight loss and weight loss percentage, etc. It is considered as superior to excess weight loss as it influences the preoperative BMI lesser. And inadequate weight loss may actually be defined as a weight loss less than 20% of the total body weight loss, as it is considered that usually this is linked to recurrence of associated conditions. So a person must lose at least 20% of their total body weight to be considered as successful outcome. And weight regain can be defined as progressive weight gain after reaching the successful nadir weight loss, more than 20% of total body weight loss. And some argue that weight regain should only be defined if there is a concomitant recurrence of comorbidities. Now, in the same review, they also studied about weight recurrence after various procedures, and it was seen that post gastric banding, the weight recurrence rates were very high, as we all know, and probably that's why it's an outdated procedure now. It was seen to be as high as about 38%. Even after post sleeve gastrectomy, the weight recurrence was quite high, and it could be about 27.8%. Post RYGP, the weight recurrence rates were very low, and as per this review, it was about 4%. Now, the thing to understand is that the previous slide, which has these absolute numbers, may not be applicable to all our patients, because there is a huge amount of inter-individual variability which is seen in response to treatment. Now, different patients may respond differently to a Roux-en-Y gastric bypass or to a sleeve gastrectomy. Unfortunately, today we don't have any method to predict who will do well with which kind of surgery. I think we're yet to get there. But probably what we need to understand ourselves, and what we also need to make our patients understand, is that every patient is different, and every patient will respond differently to a certain type of treatment that is being offered to them. So in both these charts, you will see that post, whether it's RYGB or whether it's adjustable gastric banding, we know that overall quantum of weight loss is definitely more in RYGB. But even in patients who've had RYGB, there could be a lot of variability, as is the case seen with gastric banding. Now, what are the factors for weight recurrence? Now, when we talk about factors for weight recurrence, it is usually multifactorial. Definitely our genetics play a big role. Behavior definitely is very important. Patient psychology is very important. The environment and the food availability and the ability to keep active is important. What kind of medications the patient is taking, what kind of medical conditions they're having, and about their appetite hormones, etc. Now, coming on to patient factors, I think one of the patient factors which is very important is dietary non-adherence. So if we follow up our patients after metabolic and bariatric surgery, we see that our patients are really, really good in terms of diet in the first year or so. First year, they're also very good with their follow-ups. As time passes by, they tend to slip from the diet bridge and kind of fall into their previous habits, which is a very natural and human thing to do. I think even I would do probably the same thing. Nobody can be on a very strict diet for a very long time unless you have repeated reminders from your medical team. So dietary non-adherence was one of the factors. If you see these charts, diet charts, which are after one of these patients is actually 8 years follow-up post RYGB. She actually presented to us with hypoglycemia, and when we went into the details of diet history, we saw that this patient was having huge amount of sugar with every cup of tea that she was having, and she was having many cups of tea in the whole day. So the other very important factor is having unrealistic expectations from metabolic and bariatric surgery. I think this is something where we as bariatric surgeons have also faltered in the beginning, when we ourselves thought that bariatric and metabolic surgery is probably the magic bullet for obesity, and it can treat and control, cure obesity. So I think we've all gotten wiser with time, and from cure, we know that we are only controlling the disease, and this is what we need to explain to our patients as well, that surgery will do some bit, but behavior is equally important. Physical inactivity is again very important. It could be because of non-adherence or sedentary behavior, and there could also be a certain group of patients who have barriers to exercise. So older patients with knee joint issues or any kind of mobility issues are patients who may not really lose that much weight or may be more prone to regaining weight. Mental health issues, again, very, very important. And these could be binge eating, it could be depression, depression related medications, multiple psychiatric disorders, loss of control on eating, and so on and so forth. These could again add to weight recurrence. And role of drugs. So it is important to go into the drug history of every patient. Many of these patients continue to be on antidepressants. Sometimes they have other diseases for which they need to take other medications like steroids or say propranolol or some other medications which could be adding to their weight recurrence. So it is definitely very important to know what sort of a person we are treating rather than what we are treating. So once we understand our patient, I think it becomes easy to handle that patient. Now, coming to the surgical factors, as surgeons, I think we need to look at the surgery as well. We all know that stomach is quite distensible, and sometimes when we're doing surgeries, whether it's a sleeve, whether it's a bypass, or any other operation, there could be fundus which is left behind, or there could be pouch distension in the later years as well. Now, this persistent fundus which is left behind can actually dilate a lot more as time passes by. In case of RYGB, we know that anastomotic enlargement actually is one of the important factors for weight regain, because with time, the malabsorption actually kind of goes away and there is anastomotic enlargement, and the patients can eat almost the same quantity as they were eating before bariatric surgery. There is also a concept of physiological adaptation. So we all know that the ghrelin goes down initially, GLP-1 levels rise, GIP levels rise, and all that. But with time, all these effects diminish, and there is physiological adaptation, which kind of mitigates the effect of surgery over time. The other technical issue which can lead to weight regain, especially in gastric bypasses, could be a gastrogastric fistula, and hence gastrographin or a CT scan is very important when we are evaluating a patient with a weight regain, including endoscopies. Esophageal dilatation is another factor, especially for bands. So when we were doing gastric bands, we would see that the esophagus actually becomes like a stomach, and the patient eats into the esophagus. So esophageal dilatation could lead to a lot of weight regain. Hiatus hernia is another very important aspect. A lot of our patients have hiatus hernia, and if these are not dissected properly and the posterior fundus is left behind in cases of missed hiatus hernia, it could again lead to very large pouches and can lead to weight regain. In cases of sleeve gastrectomy, initially when sleeve came in, people were using very large size bougies like 60 French, 65 French. And those were patients again who probably have skewed the sleeve data for weight recurrence, and they have definitely regained a lot more weight than the other patients with lesser, smaller bougies. Now, the third factor, which according to me is probably one of the most important factors in weight recurrence, is a disease factor. So like we spoke, that hormonal and metabolic factors, there is a lot of metabolic and physiological adaptation which happens here. There are many studies which show that ghrelin gradually increases. There are other sources of ghrelin production like the small intestine and the pancreas, and the body starts compensating over a period of time. And we see that our patients come back saying that yes, they are feeling more hungry than what they were feeling just after the surgery was done. There is also decrease in PYY and GLP-1 levels over a period of time, and that is why probably when we add medications, especially GLP-1 RA analogs, so we see that these patients again start losing weight. Post-bariatric hypoglycemia is again very, very important. These are patients who get hypoglycemic and reach out for sweets because that's the general tendency. They eat sweets, they get more hypoglycemic, they again go back and eat sweets. So in the whole process, the hypoglycemia doesn't get treated. It becomes worse, but they end up regaining a lot of weight. Higher preoperative BMI is again a predictor of weight regain. So that just shows that the disease probably is very aggressive and fast growing as compared to somebody else, especially in younger patients with very high weight. So we see 20 to 23-year-old patients with 180, 190 kilos of weight. And these are patients who are actually going to probably live for a very long time. I mean, they have a lot of long lifespan left, and hence the onus is on them on maintaining their weight, and they have a higher chance of weight recurrence. Presence
Dr.
of
Aparna,
multiple,
we are going out of the time.
yeah, just 5 minutes more. So presence of multiple comorbidities like type 2 diabetes and hypertension, etc., is also important, and they can also increase weight. So genetics again. So coming to management, I think we need to evaluate the whole the patient, especially the imaging studies and endoscopy are very important when we are managing weight regain. I think we can skip this part. Now, options for revision surgery, I think sky is the limit over here. When we talk about gastric band, it can practically be converted to any other surgery. And when we are taking a decision for a revision surgery, especially for weight recurrence, I think we need to understand what kind of geographical region we are living in, what is the diet of the patient, what is going to be the adherence level of patient in terms of supplementation, and that should probably help us to decide the kind of procedure. Just like gastric band, sleeve can also be converted to a lot of other procedures like Roux-en-Y gastric bypass, mini gastric bypass, DS, and any of the sleeve plus procedures, etc. And in case of RYGB, it gets a little more difficult and tricky. We don't have too many options left. Of course, pouch revision is one option. We could also do plication of gastrojejunostomy or excision of gastrogastric fistula, distalization and application of a band. However, most of these therapies have not yielded very great results, and they have been these patients have seen temporary weight loss with regain once again. So treating patients with weight regain after Roux-en-Y gastric bypass or a 1-anastomosis gastric bypass can be quite difficult. So these are just some of the results which are for revisional surgery after RYGB and after sleeve, and various procedures, and they have shown weight loss ranging from 19 to about 30-32%. There is definitely a role for drugs, which have started coming in now, and it's getting very exciting. I think it's the role of adjuvant drug therapy has come into obesity in a big way, even after bariatric surgery. So bariatric surgery, post-bariatric surgery weight regain can be managed quite well with the use of medications, and I think we need to move towards this direction a little bit more and try these. Again, here also there is a lot of inter-individual variability in response. There are some patients who might do really well with the drugs, and there are certain patients who may not do as well. So this is an algorithm. Maybe I will share it with you all later. But I think it is difficult to kind of make any fixed algorithm for weight recurrence after bariatric surgery. It is important that follow-up should be stressed upon, and patients are counseled about weight regain from the first consultation. It's very, very important to set the right expectations, and they must be sensitized that when they regain 4 to 5 kgs from their nadir weight, which would usually be about 3 to 4% or 5% of their total body weight, they must come back to us immediately. And diet and lifestyle modification is the first line of management, followed by weight loss medication. If they do not respond to that, then maybe revision surgery is selected for some patients. And sometimes we may need a combination of all of these together. And last but not the least, I think patients need to have the right expectation, not only from bariatric surgery, but even from revision bariatric surgery. So last slide, I think terminologies that need to go away from our vocabulary are cure, failure. There is no ideal procedure. There is no gold standard procedure. It totally depends on what suits somebody the best. and there are no undesirable results, we need to start managing obesity as a chronic progressive condition, and we need to focus more on words like remission, control, adjuvant therapy, comprehensive treatment, compliance or adherence, support, and 5-year outcomes, recurrence, and revision. So these are the options. I think what we are moving towards is combination therapy, and we need to keep titrating as per the response to treatment. And for every patient, we need to have a tailored response. What we also need to understand is that the treatment for severe obesity is lifelong. Bariatric and metabolic surgery is not the end of the road, it's actually the beginning of the journey. So, with that, I think I will end my presentation. All I would want to say is that I think as bariatric surgeons, we take a lot of onus on ourselves, not only for weight loss, but also for weight regain. We need to understand that it is nobody's fault. It's neither the patient nor the doctor's fault. We need to accept that sometimes the disease wins over us, and we need to keep caring for our patients lifelong. Thank you very much.
Thank you so much, ma'am. Very, very detailed talk. And yes, it's a subject which, we can discuss on endlessly. But I think for the sake of time, we'll just move forward and we'll just reserve all the questions for the panel discussion at the end. So thank you once again so much, ma'am. And over to you, Christopher. Chris, you're muted.
So the next speaker is Dr. Nanda Kishore, and he is a clinical director and chief surgeon of KIMS Live Life Hospital. He has done his residency in general surgery and fellowship in bariatrics, everything in US. And from US, sir has come to India to serve our people. We are very happy to have you, sir. He is an excellent bariatric surgeon who has endoscopic, who does many endoscopic bariatric procedures, as well as other advanced laparoscopic surgeries. And he is also expert in robotic procedures as well. And he is ex-treasurer, Aussie, and national advisor for AWRSC. So over to you, sir. You can talk about your endoscopic management.
Thank you, Dr. Christopher, and thank you for TUGSS for having me over today. Without further delay, let me share the screen. Oh. Right, we're going to be speaking on the role of endoscopy in bariatrics today. So just no disclosure from my side, where I work, where I come from, where I'm from Hyderabad. So endoscopy, the spectrum of uses is like mainly diagnostic and therapeutic. So when we look at this, the advantage for endoscopy is that this is a very important skill every general surgeon or a bariatric surgeon should and must possess. Because this endoscopy can actually bail you out in a lot of difficult situations if you can do it yourself, right? So it can offer you a quick diagnosis. It's very less invasive. We can repeat it any number of times and relatively low cost, but it gives you a lot of diagnostic information that you can base your clinical decisions on. So when you look at the guidelines, typically most of the associations in the world, let it be European Association of Endoscopic Surgery or American Society of Gastrointestinal and Endoscopic Surgery, everybody, including IFSO, they all recommend upper endoscopy to be performed on a bariatric patient prior to surgery. Because a lot of times, based on what you find in endoscopy, it could at times change your surgical plans. So there could be some newer pathology, like you could find masses, polyps, tumors, severe gastritis, H. pylori, you name it, any number of things, including hiatus hernia, so on and so forth. When you identify these things, there's a good chance that it may actually alter or modify your surgical algorithm or the process that you're planning to do for these patients. So when you look at the diagnostic part of the endoscopy, we use the endoscopy as a major preoperative check for most of these patients. Especially you want to look at the stomach because prior to a gastric sleeve, because you're going to be resecting it, permanent resection. Also in the mini gastric bypass or a Roux-en-Y gastric bypass, you want to evaluate the stomach because once you are done with the surgery, there's a large segment of defunctionalized stomach which you will not have easy access to. So anything that is happening inside, if there are some polyps, ulcers, masses, tumors, any malformations, it's very hard to get to them if you have not picked it up at the time of initial surgery. So at the same time, diagnosis of hiatus hernia, it's a very large hernia. Um, the recommendation still is to convert it to a Roux-en-Y gastric bypass. If it is like 2 centimeters or less, you can actually do a crural repair and still proceed with whatever surgery that you're planning to do. Similarly, now we don't do as many gastric bands as we used to before, but there's still some gastric bands lying around in patients. So we can identify a band erosion with a quick endoscopy. Naturally, we have heard a wonderful talk from Dr. Sarfaraz. It's easy to identify a leak with an endoscopy, if it's whether it's an acute setting or a chronic setting, and also to understand the stoma size when you're evaluating the anastomotic size of the GJ anastomosis and the gastric bypass. If there's any marginal ulcers, also you can look at the dilatation of sleeve or gastric pouches in. Also look at possibility of these tumors or H. pylori, etc. You can get quick biopsies and evaluate all that. So all these things are very easy and quick diagnostic modalities where endoscope hardly takes about 5 minutes to do all these things. So in a case like this, so who has a person has a large hiatus hernia, so if you can detect it preoperatively, then if it's a small hernia, like I was mentioning earlier, you can just do a crural repair and proceed with whatever. But if it is a large procedure, a large hiatus hernia, you may require to convert it to a Roux-en-Y gastric bypass. So especially when we're doing gastric balloons, a lot of times we avoid placing gastric balloons in these patients when there is a large hiatus hernia, because that can give you substantial reflux in these patients. Okay, so at the same time, you can identify these kind of tumors like GIST, etc., the neuroendocrine tumors, and again, occurrence is about 0.6 to 0.8%, not much, but when you do identify them, it gives you a very good opportunity to do a clinical and almost a therapeutic resection of these tumors. And then maybe you'll have to wait for the pathology report, maybe wait for a week or so, but it's well worth it. So a lot of times it is advisable to do endoscopy as a separate event prior to taking the patient in for a surgery. But a lot of times, like in practices like mine, patients come from a long distance, like 7 hours, 8 hours away. So they don't actually prefer to come for endoscopy once and then again come back for the actual bariatric surgery. So what we do offer them is that once we anesthetize these patients, we do the endoscopy on table. So every once in a while, we do get surprised with a newer finding where we then have to change our surgical plan. But that is the negative in that kind of approach. But about 99% of the patients do benefit from not having to go through 2 episodes of anesthesia, 2 different procedures. So that's a practice point of view. Similarly, when you identify H. pylori gastritis, if it is terrible gastritis, definitely it's a contraindication to put in any indwelling implants like a gastric balloon. At the same time, if you're doing any gastric resection surgeries, you may want to treat the H. pylori first, especially if you're making any anastomosis. There's a higher incidence of ulceration, and perforation is also possible in these kind of cases. So it's better to treat these patients preoperatively, get the condition under good control, and then you can proceed along with the definitive surgery. So when you look at the therapeutic indications of endoscopy, you have procedures for weight loss, also procedures to treat complications that occur because of bariatric surgeries. So let's look at the treatment of complications first. So one of the relatively common issue we see is that the sleeve strictures, especially when in the early part of the experience of a new surgeon, the initial fire, they tend to come very close to the incisura where they create the stricture. Or sometimes there is a little irregularity in creation of the sleeve, then there's a compensation versus overcompensation. So there's going to be a zigzag creation of the sleeve, which down the road, it creates a lot of issues to the patient where there's intolerance to solid food, there's frequent vomitings, significant nausea, etc. These kind of patients, you have to do a upper GI swallow, because interestingly, when you do a endoscopy, because of the gaseous distension, you may not see the strictures very clearly. So upper GI swallow is a better option. Then you identify and sort of figure out where the exact stricture is happening. And then endoscopically you can dilate them, right? Again, dilatation of stoma in a GJ anastomosis, if there's a stricture, especially previously we used to use circular staplers to create a gastrojejunal anastomosis, especially when you use like size 21, there's a substantial incidence of stenosis at the stoma. Then we moved on to size 25. Now we don't use the circular staplers anymore. So similarly, management of leak. When there's a leak that is happening, you can apply OTSC clips, you can do the internal drainage, pigtails, negative pressure suctions, you can put a stent. So many things that you can do with an endoscope if you're skilled with it. Also, basic things like controlling intraluminal bleed. In a gastric sleeve, occasionally you do come across a bleeder, which you can control. Similarly, anything with a pouch, the bleeding is possible. You can easily control that. We can apply a clip. We can inject, some vasoconstricting medications to control the bleed, so on and so forth. You can also use an endostitch, Apollo endostitch, to sort of put a stitch around it and control the bleeding. So many things are possible with an endoscope, and at the same time, removal of foreign bodies is also possible. So stricture dilatation, very common in the Roma gastric bypass, depending on who's and how the anastomosis is being done and what stapler is being used. There's an incidence of 3 to 27%. So, and with the sleeve, the range is 0.2 to 4%. But regardless of which procedure, if there's a significant stricture which requires a dilatation, endoscopically, if you're able to dilate it, it can actually avoid a major revisional surgery for such a patient. That's a big boon for those people. So typical endoscope that we use, it's about 9 to 10 mm. If you're using a dual channel scope, it will be a little bit more in diameter. So if you're unable to pass the scope and through that narrow stricture, typically, just once, pardon me, excuse 1 second. Right. So when you're unable to pass a scope, and if you have to use gradual dilators, you can use these smaller size catheters with balloon tips, which can gradually sequentially dilate the stricture. What you do is typically they can be hydrostatic pressure. You use water to inflate the balloon and hold it in place for a minute. And then you can repeat that 2 to 3 times. Maximum we do in the first sitting is about up to 16 millimeters. Gradually stretch it and let it go. But most of the times these strictures may recur and require frequent or repeated dilatations, which we should be ready for it. But if it's a very long-standing stricture, it is less likely to resolve with endoscopic dilatation and may require a surgical correction. So stomal stenosis, again, more common with gastric bypass, which usually gives you nausea, vomiting, dysphagia. Typical treatment is like balloon dilatation. If the balloon dilatation fails, as you see here, the balloon is being used with hydrostatic pressure. The first diagram shows you the narrowed down stoma, and then post dilatation, you can see the nicely enlarged stoma. So that gives you very immediate and quick resolution of the symptoms, but many a times these can recur and require repeated dilatation, which is not a bad idea. Otherwise, the other option is to actually go back and surgically and revise the entire gastrojejunectomy. So these things are worth giving it a shot. Similarly, sleeve stricture. Again, based on the design, you could have 2 to 3 areas of stricture narrowing, sleeve narrowing and sleeve strictures, which can range from 0.2 to 4%. Again, there's a good success rate with balloon dilatation in these patients. If the balloon dilatation and repeated balloon dilatation doesn't succeed, then the options will be to do a surgical approach where you can do a seromyotomy of the sleeve, or you can convert it into a Ruama gastric bypass or a mini gastric bypass proximal to the stricture. Marginal ulcers, again, incidence is 0.6 to 16%. Most common cause that we see is smoking, H. pylori infection, and another thing is the poor perfusion, poor vascularity of the anastomotic area. It's a very good idea to test the anastomotic area at the time of surgery with ICG and make sure that it is well perfused whereas you conduct the anastomosis. That way you can avoid this problem, because the marginal ulcers are a very difficult problem to handle, especially if patients are used to taking a lot of pain medications like NSAIDs, and these can also lead to a lot of ulceration. Typical symptoms are going to be nausea, pain, bleeding, and rarely perforation. But the symptoms can be very vague or can be very specific. But most important treatments are, one, their lifestyle modifications, smoking cessation, put them on high dose proton pump inhibitors, use sucralfate, tends to be very protective in these patients, and H. pylori treatment if there is positivity for that. And rarely, if everything fails, then you have to go for a surgical intervention. So gastric bands, we don't do them anymore that much, especially not in India. But there is this band erosion. We see it approximately 7% of bands. Typically, we see it around 1.5 to 2 years time frame, where there's a significant erosion, and they present with some nausea, vomiting, rarely hematemesis. Interestingly, sometimes they can be very benign, but they could just be presenting as an infection at the port of the band. A simple basic infection, so it looks like a skin infection, but it actually is a result of the band erosion that is tracking back to the port. So this requires surgical removal. But if the band is completely eroded or near completely eroded, we can actually remove it endoscopically. This actually avoids a entire surgical process where one would have to go in laparoscopically, remove the band, and then you would have to repair the gastric perforations where the erosion has happened. So when you remove it endoscopically, externally is already a pseudocapsule that is formed in. So it's pretty safe to use a snare kind of device to go in and cut the band and remove it transorally. So that's an option to do it with endoscope. So leak management, Dr. Sarfraz has given a wonderful, wonderful talk just before. So we can do septotomy, where we can kind of transect the septum between the abscess cavity and the gastric lumen, placing the double pigtail stents, endoscopic vacuum therapy, endoscopic clips, sealants, stents, everything is possible with the endoscope. This is how the stent is placed. Typically, what we use is the mega stents, which start from the mid to lower esophagus. They go all the way down to post-pyloric stomach. So basically what happens is that the entire leaking area is bypassed. This is a fully covered stent. And by negating both the gastroesophageal sphincter, the lower esophageal sphincter, as well as the pylorus, it creates a low pressure system so that the transit of the whatever the consumed food goes through very quickly, and then the leak area is fully covered by the stent. Typically, it works very well for the acute leaks, but not so much so for the delayed or late leaks. So typically, these stents are fully covered and they need to be removed after 4 to 6 weeks. Endoscopic clipping, these are called OTSC, over the scope clips or ovesco clips. Typically, where you find the leaking area, you can endoscopically go in there, get a good purchase. You have a kind of a corkscrew mechanism where you can drag the tissue into the mechanism of this particular OTSC clip and deploy the clip. So it is a full thickness clip. Actually, it has a very sharp, pointy jaws, and it's a very high pressure jaws. Actually, it holds the entire gastric wall, the full thickness, and it gives you pretty good results with control of a localized smaller leaks, not for the very big leaks. So therapeutic procedures, you have endoscopic gastric balloon, you have sleeve gastroplasty, endoscopic, DJ bypass sleeves, you have the gastroduodenal bypass liners, magnetic compression gastrojejunostomy is a new thing coming up, transpyloric shuttle, you have POSE, which is a primary obesity surgery done endoluminally, asparasis system, which is fallen out of favor now, mucosal resurfacing for diabetes. Again, it is an emerging science. So some of those examples are here. Intragastric balloons, we have several models. We have SPATS, third generation balloon, we have Orbera, Reshape, Duo, Obalon, Allurion, many companies producing various kinds of balloons with different kind of mechanisms and variable lifetime life of the balloon. So some range from 3 months to 6 months to 1 year. And some are, a couple of them are adjustable, some are not. Excuse me, average excess weight loss is around 17 to 30% in most of these patients. But once the balloon is removed, there's a good amount of weight recurrence. We do notice that unless they're very well managed. There's a very high rate of post-operative nausea and vomiting in the first 4 to 5 days after the balloon placement. We have to counsel these patients thoroughly to expect that situation, because many a times if they're not counseled well, within the next 1 or 2 days they'll come back for balloon explantation. So we need to be very careful with that. And we need to treat them with adequate medications to reduce the nausea, pain, discomfort, and the cramping of the stomach. We typically use the ondansetron, we use the buscopan and pain medications to control them. If the symptoms are too much, then we even put them on IV fluids to tide them over that first 2 to 3 days, and then they do really well after that. Endoluminal bypass liners, the first model was a disaster because it used to have metal barbs that was placed in the first part of the duodenum near the duodenal bulb. Those barbs used to penetrate through the wall of the duodenum, created hepatic abscesses, etc. So later on, the design has been changed, and then the metal barbs were removed with self-retaining, a softer mechanism. Typically, what this liner does is that it bypasses the entire mucosa of the duodenum, goes all the way to the jejunum. So the idea is, if the exposure of food is not happening into the duodenal mucosa, there's a good resolution of type 2 diabetes. This is the...
Dr. Nandit, we are
Yes.
getting out of time. We have panel discussions as well.
Finishing up. So DJ bypass sleeves, that's it. And then it's emerging science, and endoscopic sleeve gastroplasty, it's fairly popular. Gives you pretty good results. We require a double channel endoscope to do this. Again, this is the way to do the endoscopic sleeve gastroplasty with a multi-point suturing, where we will reduce the size of the entire fundus all the way down to the body, reducing the capacity. Fundus is sutured in pose procedure, again with endoscopically, reducing the size of the fundus. And there's a newer thing called transpyloric shuttle. It's like a spherical bulb which is there um, at the pyloric valve, especially when you're eating food. The larger part of the ball just goes and blocks the gastric outlet, creates a transient gastric outlet obstruction, makes you feel full faster, and delays the gastric emptying. That's how these things work. And magnetic compression gastrojejunostomy is up and coming technology, where endoscopically you'll be able to create a gastrojejunostomy or a jejunojejunostomy by deploying very high powered magnets. Due to adherence of the magnets, they create pressure necrosis, thereby creating an anastomosis in that area. And duodenal mucosal resurfacing for diabetes is again an emerging technology, where we can use hot water through a contained bulb to burn the mucosal lining of the duodenum, so that it also gives you good results with diabetes resolution. And that should end my talk. Thank you very much.
Sir, it was a wonderful talk. So, yeah. So it was a wonderful talk, and so as what I can get from this talk is the surgeon has to be equally a good endoscopist to treat his own complications, as well as to know to do a primary procedure endoscopically. That is what it is, right, sir?
Knowing endoscopy opens up an entirely new world
Exactly.
to a surgeon.
Exactly.
Absolutely.
Yeah. So due to time constraints, we'll go to the next part of the meeting, which is the complications in bariatric surgery. So I would like to introduce Dr. Chirag Parikh. He's a practicing senior laparoscopic bariatric and GA surgeon in Vadodara. He's a professor of surgery at Parul University. and he is the owner and director of Devarsh Bariatrics, and he has been trained from the NHS UK, and he has done multiple presentation publications in bariatric surgery. And over to you, sir, Dr. Chirag. So your voice is, I think
Yeah.
it's, yeah.
Okay.
Yes.
Yeah, I'm with you. Thank you very much, Christopher, for such a nice introduction. And his flow is going very smoothly today. So I won't waste much time and just try to present my. Is my screen visible?
Yes, sir, it's visible. Can you make it from a full slide? Yeah. Yes. Yeah.
Okay. So this is one of the complication which I have come across in a patient who had a ruined by gastric bypass presented with intestinal obstruction. So as we know that commonly performed procedures are sleeve gastrectomy, Roentgen bypass, and mini gastric bypass. Uh, Although Roentgen gastric bypass is nowadays being performed less frequently, but they do happen, and there is rare complication is internal hernia. So we came across this patient, 54-year-old gentleman, presented with pain, vomiting, and hiccups. On investigation, it showed anemia, acute renal failure, and dilated jejunal loops with closed loop obstruction on CT scan. Unfortunately, I haven't have a video clip of CT, but it showed closed loop obstruction. Patient was previously operated for RYGP in 2011 at one of the center in Mumbai, and his weight at the time was 160 kg. He lost and maintained good weight so far. His current weight was 76 kg. So after admission, we managed him conservatively for a couple of days for correction of anemia and acute renal failure. And then we took him for surgery. So before I will just show the surgery video clip, we just need to think about what's the internal hernia and how it occurs in going by gastric bypass. So it depends on which kind of bypass is done, either anticolic or retrocolic. So if we commonly perform is anticolic bypass, once we bring the jejunal loop up towards the pouch, we create a two potential spaces here. There's a one space below the transverse mesocolon here, number one, that is Peterson's defect. And another one, that is jejunostomy, which we do. It creates another potential space, that is mesomesenteric defect. So these two space generally we try to close it in the primary surgery itself, because nowadays there are a lot of papers has come up with internal hernia. So since 2015, sort of we try to close these defects. So nowadays to avoid having internal hernia. And another third potential space here, when you do a retrocolic jejunal bypass, then the space behind the transverse mesocolon. So there's another third space we can have internal hernia. So coming to port placement, it's a standard placement for any uh, uh, bariatric surgery. I actually kept umbilical port because I need to have access in the small bowel lips. So just a video clip running now. So upon entry inside, as we expected, a lot of adhesions were there. So all the adhesions were divided carefully using cold scissors as and when and require, and harmonic. So gradual all the adhesion lysis was done. There's a lot of adhesions around the pouch, jejunostomy, and around the liver, which was divided. And then we try to look for junction of dilated and collapsed loops, try to find where the obstruction is. And this is actually, that was the lateral abdominal wall adhesion, which was culprit of patient developing symptoms of obstruction. So in my experience, this was actually my third case of internal hernia, where generally, if you try to find out randomly, you won't find any cutoff point, but where you should trace it from the ileocecal junction. So gradually you trace from ileocecal junction proximally, follow the common channel, and then you will find uh, jejunal anastomosis from where here is the big gap you can see from where the herniation was there. So again, the interbowel loop adhesions were divided carefully. And finally, we find the area of obstruction. So I tried to reduce the hernia many times during this surgery, but it was not happening because of the adhesions. But once I divided all the adhesions, then you can see here the afferent loop here, the jejunal loops were dilated, it was going through, and now it has been corrected. So again, the pouch jejunostomy patency was checked, and by putting the uh, gastric compression tube, calibration tube through the anastomosis, and finally the defect was closed using wheellock stitch. So it was a huge gap, took time to close. And then again, re check of anatomy was done. So these are happy patient post-op. So coming to literature review, incidence of internal hernia is between 0.9 to 4.5%. As I mentioned, there are three varieties of hernias. I've already explained that. There is a classification about this internal herniation for documentation purpose. So it depends on the space, either Peterson space or retroenterostomy space, or it's called Prolin space. Another thing, variety of classification depending on the direction of the hernia. So either it's a right to left hernia or left to right hernia. That is also important to document. And what part of bowel loop is been herniated, either it's alimentary limb or BP limb or common channel. So that is the classification we describe in literature. So this is some references I use to this talk. Thank you.
Thank you so much, Dr. Chirag. It takes a lot of courage and a lot of patience to deal with an internal hernia, and you've dealt with three, like you said. Kudos on that. We'll just continue with
Thank
the
you.
rest of the sessions. Our next speaker is somebody who's already been speaking from the start, Dr. Christopher. He is our TUGSS Bariatric Coordinator. He has trained in Taiwan with Dr. C.K. Huang extensively. And right now he's running his own bariatric center called Barrios Clinic down south. And this was the first bariatric center which was established in southern Tamil Nadu. He's also a visiting consultant at Apollo Hospital, Chennai. And over to you, Chris.
Yeah, hi. I hope my slide is visible.
Yes, it is.
Yeah. So this is actually a case where there was an MGB leak, which we managed by a hybrid lap and endoscopic approach. So I'm Dr. Christopher. I am a consultant bariatric surgeon and a visiting consultant at Apollo Hospital, Vanagaram, Chennai. So 410 leaks has been reported in around 44,318 patients of OAGB published, and which represents a prevalence of 1% of leaks after OAGB. So 62.1% of patients with leaks had to undergo another surgery due to leak. The most commonly performed procedure was like peritoneal washout and drainage in 30.8% of patients, followed by conversion to Roux-en-Y gastric bypass in 9.6% of patients. So medical treatment with antibiotics with or without total parenteral nutrition alone was conducted in 13.6 patients. Among the patients with leak, the mortality rate related to the leak was 1.95%, and the mortality due to leak in the population of OAGB was 0.02%. So, case history, this patient was a 39 years old male patient, BMA of 54. There was no comorbidities and no reflex symptoms, had OSA and was optimized with CPAP for 1 month, and he underwent MGB on 4th of August last year. So this is the video, a short video which shows the port insertion, the normal MGB ports, and then the liver traction with the needle holder, and then we start with the dissection. So we place gauze piece at the left crus, and this is the omental division. So after that, the bowel counting is done. So we have done around 160 centimeter of bypass. So we have secured the jejunum to the stomach with a stay suture. So the lesser curve dissection was started. So during the lesser curve dissection, probably there was some thermal injury because of the ligosure usage. So which we actually, we started firing the stapler. The first stapler was fired and the subsequent staplers were fired. So meanwhile, while firing, we just saw there was a thermal injury on the posterior aspect of the tube. So that that was the thermal injury, and that actually was sutured. So after the subsequent firing, we sutured that thermal injury. Yeah, so once it was done, we continued our anastomosis. So the anastomosis was done. And the regular suturing. We had used a double staple technique in this patient, and then the edges were sutured. Yeah, this is the final tube, the final creation of the MGB anastomosis. So once this is done, then we did a leak test, which was negative. There was no air bubble seen. But still we placed a drain because it was done in another hospital. So we have placed a drain actually, and then we covered with the omentum. So this was done. So post-op, after the surgery, the patient was extubated immediately and shifted to the ICU for post-op care. Patient was kept NPO for the night. There was sudden tachycardia around 8 hours post-surgery. And the first post-op day, there was a contrast dye study done with the CT, which revealed a perisplenic leak. So this is the CT picture. So this is the CT which shows a perisplenic leak. Yeah. So once after that, the pulse rate was around 138 beats per minute. The SpO2 was 99, body temperature was 98.6, and blood pressure was 150 by 100. The patient condition deteriorated, so he was posted for a DLAP and proceed. So medical gastroenterologist was standby to do the intra-op endoscopy. So this is the procedure done the next day evening, immediately once we found out that there was a leak. So again, we put the ports and the drain was removed. And this is the intra picture video. So as you can see, there was full of flakes, not frank pus though. So we tried to identify the leak site. We checked all the thermal injury site, what we were initially we have seen in the first surgery, but we couldn't identify any. So then we actually made the medical gastro to come with the endoscope. So this is the endoscopy which is inside. So the internal view we can see now. Shortly it will come. Yeah, this is the endoscopic view. So this is the staple line. So we went all the way down up to the afferent limb, afferent and efferent. So these are the afferent and efferent. So everything was okay. So again, we filled saline and actually we made the endoscopist to blow air through the endoscope and we found the air bubble. So again, we went and saw, and this was the opening. This was the leak site, which was like around 5 to 6 centimeters from the OG junction, which was almost just from the G junction. So the endoscopist suggested that we'll go with the OTSE clip. So this is the OTSE clip. We didn't have that video. So this is how it has been placed. So this is the clip placement. So after the clip was deployed, we again tried the leak test. So it was negative. There was no leak. But still, to be on the safer side, we wanted to deploy another stent also, so that there is no issues post-op. So now there was no leak. Yeah, this is the stent, which was a covered stent, which was put from the GE up to the anastomosis. Yeah, so post-operatively, the patient was shifted to ICU and was sedated and ventilated. He was extubated the next day. Slowly, oxygen requirements was tapered. He was given clear liquids and he tolerated well, and hemodynamically he became better. He was shifted to the wards and managed conservatively. And CT screening showed stent was in position. He was clinically stable and was discharged. After 6 weeks, the stent was removed and the OTSC clip was in place. The recent endoscopy, which was done in March 2024, 2-3 months back, showed there was no clip inside and the leak side was completely healed. The patient is in follow-up and has already lost about 40 kgs till now. And this is the recent endoscopic video, which shows that the entire leak site has healed and there is no clip in place. So this is into the front. And this is the site, which is completely healed. Yes. So the message here is actually the thermal injury, which can be dangerous, and it has to be very meticulously dealt with while you actually do the dissection. And that is the only thing I wanted to convey. Thank you so much.
Nice presentation, Dr. Christopher.
Yeah, thank you, sir. Thank you, sir.
Yeah, I agree. Very nice presentation. Good learning.
Thank you, sir. So I think we'll move on to the next person, which will be Anirudh Rajkumar. So Anirudh is actually a very close friend of mine, and he has been always there whenever I had a trouble. He's a laparoscopic and robotic surgeon, joint director, Lifeline Hospital, Chennai, and also he's a visiting consultant at Lifeline Hospital, Durgapur, and a specialist in laparoscopic upper GI surgery and bariatric surgery. And he is also fond of Shas and Chashi, and they are the first in Chennai to use the swallowable balloon for weight loss. And I welcome Anirudh. Apparently, I'm sharing his presentation because he's not able to share. So just give me a minute.
Thank you all, and thank you, Christopher, for the great introduction.
Yes.
So I'm just going to share this, talk about this little complication that a colleague of mine had undergone, and I had gone for the rescue. So I'd like to proceed with this. Next. So 39-year-old male with a 46 BMI, 122 kilos, no hypertension, recent diabetes on OHAs, HbA1c 8.8, and known case of sleep apnea, no GERD symptoms. So the primary surgeon, next please. Next. Yeah. The primary surgeon had evaluated and planned for a sleeve gastrectomy. C-peptide was in the upper normal limit. Ultrasound showed a fatty liver grade 3, mild antral gastritis, no hiatus hernia. Next. So he was posted for a lap sleeve gastrectomy after obtaining complete fitness. Next. So the primary surgeon had used the regular ports and proceeded with the sleeve gastrectomy as always. using the ultrasonic dissection, gastrolysis was being done. And this surgeon hadn't performed too many bariatric surgeries before. And there was a unit which did not have too many set protocols in place. And you can see the upper fundus being mobilized, and then further gastrolysis being done distally. The gastropancreatic adhesions being released over here. Now you can continue. So further dissection being done up to 2 centimeters to 3 centimeters from the pylorus. And you can see the first stapler being fired. He had used a purple stapler. And once the purple stapler was applied, that's when apparently their anesthetist realized that he could not take the Ryle's tube out. And there you can see that the Ryle's tube had actually been stapled, and you had one end that was stuck inside along with the actual pouch, and the other end that was taken out by the anesthetist once the stapling was complete. So you can see they had called me for the rescue at that time, and luckily I was not too far away. And by the time I went in, I decided to open out the specimen site of the stomach, since that would be redundant anyway. And I decided to do a little bit of dissection, approach, and find the distal end of the orogastric tube. And I found that it was still stuck, so for which I had to open out the specimen site further. And then as we released it further, we could free it completely with the stapled end. So this is the distal end of the Ryle's tube, which I had removed after that. You can see it over here. And the other end was pulled back by the anesthetist. Only then they decided to push in the gastric calibration tube. So we had 2-3 options at this stage. So we could have just sutured the end that was connecting the specimen stomach to the actual stomach, and continued with the stapler firing over the bougie, which was what was planned initially. So you can see I was ensuring that the sutured site was being included in the stapler line. There you can see a bit of doubt regarding closeness to the incisura. So as all of you know, a narrowed incisura can very well be a disaster in terms of sleeve leak. And there you can see I had proceeded with completing the sleeve, and I make it a point to routinely imbricate my upper sleeve end. The upper stapler line, you can see I always do a Lambert stitch and do an omentopexy on top of the imbrication. Some people might call it an overkill, but I prefer playing safe. So at least in the upper stapler line where majority of the leaks happen, I make sure I do an imbrication and an omentopexy along with that. So once that was done, I was still in a bit of a dilemma whether we need to complete this sleeve or do anything further beyond this. So you can see I'm imbricating even the end which was close to the opening where the Ryle's tube was retrieved. But then I decided it would be safer to decompress this sleeve gastrectomy, as literature shows there's nearly a 20 to 30% chance of leak in patients who've undergone inadvertent OGT stapling. And hence, I decided to convert this procedure into a procedure which I've now grown to love and I'm doing a lot of them. It's called as the SASJ, or single anastomosis sleeve jejunostomy. So you can see the opening is made about 4 centimeters from the pylorus, and I've anastomosed the jejunum about 170 centimeters from the DJ flexure. And you can see using a V-lock, I would be closing the common enterotomy. And usually in a SAS-J or a single anastomosis sleeve jejunostomy, the lie is usually very nice and vertical when it comes to the anastomosis. And it's almost always a posterior anastomosis, as you can see over here. So there was this element of doubt whether I could have just imbricated and left that alone, but I decided to decompress the anastomosis as it's always safety first, and making sure that decompression was done. And so I can see somebody has asked me in the chat section why 170 centimeters is used, because that is usually the BP limb length that we use for most SAS-Js or an MGB, because this would also give the patient a benefit of a metabolic procedure, as the patient also had recent diabetes. So started on liquids on POD1. We had placed a drain tube, which we normally do not keep in most of our bariatric cases, which was removed on POD3, and the patient was discharged on POD3. Visited the primary surgeon after 1 week, a normal USG abdomen, and following 2 weeks of a liquid diet, he was back to a normal diet. So at 6 months follow-up, now that we had done this SAS-J procedure, there was a significant drop in the HbA1c, and he had lost around 35 kilos of weight, no hypertension, stopped all regular medications and UDCA, and he's on multivitamins. So you can see quite a few papers have come on stapler malfunctions. There was one big meta-analysis of nearly around 3,000 cases from Boston Clinic, if I'm not mistaken, where they'd shown that the leak rate is nearly 20 to 30%, and the chance of conversion to open surgery is around 15 to 20% for many of these inadvertent injuries. It's one of the most underreported complications that have happened. You can see Kalikoglu et al. Inadvertent stapling, where they've checked and found the stapling in nearly 3 out of 1,000 cases. And you can see one of the most underreported complications. And you can see here there's a late gastrogastric fistula where they had found that there was an unexpected foreign body of an impacted bit of the orogastric tube, which was inadvertently stapled. So to avoid misfires, always follow the manufacturer's instructions, verify the stapler, make sure you're using the right thickness for right stapler for the right thickness of tissue, proper tissue preparation, appropriate stapler selection. Next. Careful handling. Make sure the right protocols are in place. Make sure you ensure that there's no Ryle's tube or orogastric tube in, and it's better to keep a bougie, because the chances of stapling a gastric calibration tube is much, much, much less. And even in the GCTs, I'm sure many of our seniors here would know, the initial days, they were using these hollow compressible GCTs, the bougies, which also had a chance of being stapled. But the current newer GCTs with a blunt tip have a much less chance of being stapled or included in an inadvertent stapler. Correct placement, maintain visibility, make sure it's all under position, and make sure that you have these protocols set in place. And there should be a proper teamwork and proper coordination between the anesthetist and the surgeon. Even if the surgeon forgets, the anesthetist should not. So in our OTs, we make it a point to make sure there's no Ryle's tube or temperature probe in the place. And a GCT is always safer. Thank you very much.
Thank you, Anirudh. It was an excellent presentation and you have managed the case very well. So now we have, yeah. So we have already, we have completed at the right time. We have another 10 minutes for the questions. I think there are a few questions in the box. So I think the panelists and the speakers can answer that. We'll go with why 170 centimeter jejunal bypass for decompression? That is a question for Anirudh.
Yes, that is the standard BP limb that we use for most mini-gastric bypasses and SAS-Js as well, because so the recommendation for those who do SAS-J procedures, keep it at 200 centimeters. Here, we'd like to keep it at 170 centimeters to avoid possible malnutrition. And
Okay.
yes, this is a loop GJ. Mr. Dr. Suraj has asked how
Yeah.
it will offer metabolic benefit when the sleeve is with a normal functioning pyloresis in place.
Yeah.
Yes. So you can see there is a lot of data coming out on SASJ and SASI. And you can see in these procedures, though it's a loop with the remaining pyloresis in place, we should not forget that the pylorus is functioning and is quite tight. And by proper peristalsis and by having a long anastomosis, which is around 6 centimeters, the normal route of the foot and chyle will usually go down the jejunum. So any kind of mid-gut stimulation, any kind of jejunal stimulation will definitely offer any kind of metabolic effect.
Yeah. So other thing is, what is your opinion of swallowable magnets in metabolic surgery for diabetes resolution and weight loss? So I think it is just now it is coming in into the field now. I think swallowable magnets. What is your idea?
So I think Dr. Nandakishore and
Yeah, I
Sarfraz sir
think
could
yeah.
probably
Yeah, sorry
throw
guys,
some
I
light
don't
on the
have
topic.
any first-hand experience with this swallowable magnets. Maybe for the next talk, I'll have some more.
Sure, sir.
I
So
think
what
Dr.
is the
Mohit and team have started doing a few.
yes,
It's
yes,
still
yeah,
the GI
Yeah.
window and the barrier. So there's still a lot of controversy regarding that because the whole thing seems quite relatively blind. But I guess I think more time will be needed for more data on this, right?
Yeah,
yes.
absolutely.
And the other question, like it was previously asked, what is your opinion regarding placement of intragastric balloon for weight loss? So
Yeah,
Nandakishore
it's a
sir, yeah,
yeah, it's a very good procedure, especially people with the body mass index less than 32. It's a great option, and those people who are young and don't want to have any surgical incisions on their tummy. There are some youngsters who are still in their growth spurt, or rather they're not fully grown adults yet. Yeah, but they're fairly obese, young children. They are good candidates for that. In our practice, we also see some movie personalities and some models, etc. Those kind of folks who don't want any surgical incisions on their tummy because of their professional reasons. All these people are good candidates. Also, some of the older people who are not good candidates for a major bariatric surgery, you can also utilize these gastric balloons to kind of drop a little bit of weight prior to a joint replacement or prior to any other major surgery, etc. These are good options. So we have, as I mentioned earlier, we have balloons that last 3 months to 6 months to 1 year. Some are adjustable, some are not, depending on the requirement of the patient. We can offer, most of them are endoscopic. There's one model which can be done without endoscope. Although the results of that particular balloon are kind of mixed up, but these are the options that are available. But balloon itself is a wonderful option for patients who want to lose about 14 to 20 kilo weight loss. I think that's a good option.
nice sir. And there is one more question for you, sir. Are there any complications with the endoscopic treatment, like generalized peritonitis after rupture of well-contained collection? And with your experience, sometimes did you convert to open surgery? One of the question is that.
In general practice, what we do is that whenever we go with endoscope into this cavity, so mainly we're going transgastric, and then going into the collection. For the most part, the idea is to open the communication wider between the collection and the gastric lumen so that it drains internally. And then we can also put the double J pigtails into the collection or put in the negative pressure suction, etc. So the intervention of endoscope going into the particular collection and making it worse and making into substantial peritonitis, it's theoretically possible, but we haven't seen that many. Yeah.
Okay, sir, sure. And Anirudh, you have got a question. What is the incidence of dumping syndrome with such wide anastomosis in SASJ? Also, the incidence of troublesome bile reflux.
Okay, so dumping syndrome, luckily, because the pylorus is still in place, the dumping syndrome is nearly the same as a mini-gastric bypass. But in this case, we want more of the contents to enter the jejunum, for which we require this dumping. But still, as per the data for now, the dumping syndrome is around anywhere between 10 to 15%. Again, it's not clear enough yet. Right now, none of our patients and none of the patients of the surgeons who are regularly doing the SASJ have experienced any patients with troublesome dumping syndrome. It's comparable to that of a mini gastric bypass, and the latest data is saying it's a lot less than in a mini gastric bypass. And as for bile reflux, again, when you have the direction as a long vertical posterior anastomosis, the chance of bile reflux into the stomach is again much less than if you have than without a long vertical anastomosis. And that's the reason this surgery is required where you have a proper vertical posterior anastomosis. And the other thing that you should be aware of is when you have bile touching the stomach, you do have acid to neutralize it. In many of the other cases, like many other surgeries, like a long pouch RYGB, where you have a long pouch without much, and you don't have any bile in the jejunum, where you have an isolated roux loop, the chance of marginal and anastomotic ulcers are much higher. But in this case, you have enough bile and acid to neutralize it as well. So the chance and the incidence is much less. And as per latest data, the degree of malnutrition and nourishment complications is a lot less, again, for the same fact that the pylorus is still intact. So it may not be as powerful a procedure as a mini gastric bypass, but definitely the malnourishment complications aren't as much either.
I think the
I think one of the
biliary stitch works for this bile reflex. I think so, no? You
Yes, that's
take
right. But here it's a long anastomosis, so you need to make sure you have sufficient dumping into the jejunum. So it should be a long, nice posterior anastomosis.
Yeah, Chirag sir, you were about to tell something. Yeah.
Yeah, I think one of the advantage of this is you have a pylorus intact, so you can have some endoscopic procedures in future, surveillance endoscopy or ERCP in future as compared to RYGP.
The biliary channel is still intact. That's right.
Yeah.
As compared to an RYGB or an MGB, though I do a lot of MGB procedures,
that's a little
you completely
more
lose access. But in this, you have an advantage of that. And also, this is a very easily reversible procedure as well. So I think there will be more and more surgeons increasingly taking up the SASJ as a bypass procedure, as a metabolic procedure. And
by the way, for patients, lot of sleeve plus procedures, we call it, like a lot of procedures like coming up with this method. Yeah,
definitely.
Exactly.
There is one,
and this works quite well for patients with acid reflux as well. So I think we are coming up with a paper, myself, Dr. Surendra Ugale, Dr. Raj Pranayappan, we're all coming up with some more data on this, but the preliminary findings seem to be excellent resolution of gastroesophageal reflux disease as well. So MGB works quite well in GERD, and SASJ seems to be working very well as well. But again, a little bit more detail and more data would be required in this. I'm sure Nandakishore sir can talk more about a few more sleeve plus procedures, as he does a lot of sleeve plus PJB surgeries as well.
Yeah, there are actually very good results with most of these sleeve plus methods. They are equal or better than the older methodology like Roux-en-Y gastric bypass or even MGB without having that malabsorptive profile. So there's no malabsorption, protein energy malnutrition, those kind of things. You avoid that, yet you get the beneficial effect of weight loss, etc. So especially we have done a pretty decent series of PJBs. I think we've probably crossed around close to 200 of them, and they're doing really well. Excellent results. The mineral deficiency or protein energy malnutrition is similar to a gastric sleeve, nothing more, nothing less. So it's a wonderful procedure to try, and SASJ is also pretty nice.
Yeah, the last question was potential negative side effects and complications associated with bariatric surgery in the treatment of metabolic disease. I think it is the same thing what we are all aware of, the leaks, and what is your take, Anirudh and Nandakishore sir? I think Aparna ma'am is about to leave. Yeah, you can tell about
so Dr. Sarfaraz and Nandakishore sir can enlighten us on this. That would be good as well. Is Dr. Sarfaraz around?
So bariatric
he also
he's left us. Okay.
Yeah.
I think it is more of a beneficial for controlling metabolic disease, all bariatric surgeries.
Christopher.
But one of the demerit might be if patient is diabetic and gains weight, then reappearance of diabetes is one of the complication. But again, that can be tackled with further procedures or medications.
Yes, sir.
And some of the procedures like dumping syndromes, like sudden hypoglycemia, that's one of the
Hello.
complication can happen
Yeah.
following this.
So
We have to finish the program in
yes,
time,
sir. Yeah.
Christopher.
It's about to get over. Yeah, we are done, almost done. Yeah, I thank each and every speakers here, panelists, and also the moderators for such an excellent time. And I thank TUGSS India for giving this opportunity for me to coordinate and also to do this program. And I thank Dr. Vikas Jain for giving this opportunity. Dr. Vikas, your comments?
Yeah, it was really a wonderful session, and Christopher, you have organized it well. We have run very smoothly. Everyone has presented very well, and even the chat box, I could see that it was full of the discussion. And definitely, we will be going on like this in the further coming months also. Every month, we are doing same presentations, but on the different topics from the benign and malignant in all upper GI, hernia, and GI surgeries. So I hope all the faculties will be remain in touch with us and for the further sessions. Thank you all.
Yeah. Thank you. Thank you so much.
Thank you.
Everybody.
Thank you, TUGSS. Thank you.
Great session. Thank you all. Thank you
Thank
all for this
you.
opportunity.
Thank you, everyone.
Thank you, Nidhi. Thank you.
Thanks.
Thank you.